Hello everyone, welcome to Mental Health Nursing, Nursing 244. This is part one of the introduction to mental health nursing. What is mental health? The U.S. Department of Health and Human Services in 1999 defined mental health as the successful performance of mental function, resulting in productive activities, fulfilling relationships, and the ability to adapt to change and cope with adversity. So what then is mental illness? The American Psychiatric Association defined mental illness as a clinically significant behavioral or psychological syndrome experienced by a person marked by distress, disability, or the risk of suffering, disability, or loss of freedom. Some of the mental illnesses that we'll talk about this mini-master: eating disorders, schizophrenia, mood disorders such as all of the depressive disorders, bipolar disorder, anxiety disorders, and so on, we will be discussing. So when we think about mental illness, we need to look at the statistics. And so what we're going to talk about here is the incidence and prevalence of mental illness in the U.S. The first bullet point says, in any given year, more than 57.7 million Americans have a diagnosable mental disorder. 1/2 of all citizens have a mental illness at some time in their lives, but most never seek treatment. Mental illness is the second leading cause of disability. So what I want you to understand is that mental illness strikes people of all ages and knows no racial, ethnic, gender, or socioeconomic variables. According to the 2004 census, 26.2% of people 18 years or older had a diagnosable mental disorder. When you look at mental illness as the second leading cause of disability, this follows heart disease, which is the first leading cause of disability. But for people 15 to 44 years of age, mental illness is the leading cause of disability. So to follow along on this slide, you can see that the fourth bullet point says approximately 15% of adults with mental illness can be classified under a term called dual diagnosis. What does this mean? Well, dual diagnosis refers to a person with mental illness who also has a coexisting problem with drugs or alcohol. Nearly 50% of people with any mental disorder meet the criteria for 2 or more disorders. And more about that later. At least 20% of U.S. children have a diagnosable mental disorder. More than 5 million adults experience severely impaired functioning. In adults 18 to 54 years old, 18.1% have anxiety disorders, 9.5% have mood disorders, and 1.1% have schizophrenia. It is thought among older adults that 8 to 15% of them have depression, and people over 65 have the highest suicide rates. It is thought that about 25% of homeless people have schizophrenia or bipolar disorder. At any given time, more people with untreated severe psychiatric illness are living on the U.S. streets than are receiving care in the hospitals. It's quite a staggering statistic. So what are some of the elements of mental health? The first one is self-governance. And this is where you act independently, dependently, or interdependently as the need arises without permanently losing autonomy. Progress toward growth or self-realization. This is where you're willing to move forward to maximize your capabilities. Tolerance of uncertainty. Facing the uncertainty of life and the certainty of death with faith and hope. Self-esteem is being aware and accepting of personal abilities and limitations through lifelong self-reflection and feedback from others. Reality orientation means distinguishing fact from fantasy and behaving accordingly. Mastery of environment is interacting competently, effectively, and creatively with and influencing environmental context. Lastly, stress management. Experiencing congruent emotions in daily life and tolerating stress-provoking situations in an adaptive, creative, and flexible way, knowing that any negative feelings are time-limited. So some of the influences on mental health, you can see there's biologic influences. You've got your prenatal, your perinatal, and your neonatal events. You've got a person's physical health status, nutrition, history of injuries, neuroanatomy, and we'll be looking at more of that as some causes to mental illness as we go along. And physiology, certainly. We'll be talking about some of those brain chemicals. Psychological illnesses, interactions, intelligence quotient, self-concept, skills, creativity, emotional developmental level. And lastly, your socio-cultural influences, family stability, ethnicity, housing, child-rearing patterns, economic level, religion, values, and beliefs. These all play in to a person's mental health. So, what causes mental illness anyway? Well, what you have to keep in mind is that specific causes are largely unidentified and generally seem to involve complex interactions among genetic predispositions and environmental influences. So here's what they think: genetic predisposition, environmental influence. And you have to ask the question, do variations in genes disrupt healthy brain function? Then, under certain environmental conditions, does this disruption result in mental illness? So something to think about. What two main classification systems are used by professionals to diagnose mental illness? WHO's classification of mental and behavioral disorders, the ICD-10, being the latest in the series, originating in the 1850s. The next one is the APA's, or the American Psychological Association's, Diagnostic and Statistical Manual of Mental Disorders, which was developed more than 5 decades ago, is currently on the sixth revision. The DSM is published by the APA and is used as a diagnostic tool to identify mental health diagnoses. Nurses use the DSM in the mental health setting to identify diagnoses and diagnostic criteria in which to guide their assessment, to identify their nursing diagnoses, and to plan, implement, and evaluate care. So what are some of the national healthcare priorities for prevention and treatment of mental illness? It has to do with health promotion and illness prevention. Attention to medically underserved populations is so important. Involvement of managed care and behavioral health. We'll talk more about that later. Quality management, including client outcomes. Expanded practice of advanced clinical healthcare providers, including nurse practitioners. Community-based primary care. The influence of consumer and family advocacy groups. Decreased benefits through Medicare, Medicaid, and disability programs. So these all influence the prevention and treatment of mental illness. Here's a little YouTube clip, and if you're so inspired, you can watch this. It's treatment for mental illness framed in a historical perspective, and it has to do, it's a little video shot around a hospital, a mental asylum, if you will, up in New England. But it's very interesting to watch it and think about, you know, what mental illness care looked like, or treatment looked like, and kind of taking us forward. What are some of the issues in treating mental illness? Well, certainly cost-related issues. Cost is high and increasing yearly. Inpatient care is very expensive. Other forms of treatment are also very costly. As costs have increased, then the involvement of behavioral managed care has followed suit, resulting in a couple of things: decreased hospital admissions and cost containment efforts, which restrict the more expensive meds, even if those meds might be more effective and have less side effects. Remember, I don't know if you have healthcare or prescription insurance or not, but if you do, you're probably very familiar with tiers and what your insurance will pay for and what they won't. It is important to note that in the long run, many of these newer meds that are more effective with fewer side effects could actually help us increase adherence to the drug regimen and result in improved client outcomes, with actually a savings in, as you see, a decrease in relapses and hospitalizations. Many managed care gatekeepers have denied or restricted access to needed services as well, and therefore they've contributed to discouragement, distress, and despair for clients and families. The next issue is stigma. Stigma has to do with public misunderstandings, misconceptions, and other associated factors which all serve to enhance the public's perceptions of differentness associated with people with mental illness. Some people avoid anyone with a psychiatric label or even treat him or her unkindly or maliciously. How has the media, like movies, television, literature, contributed to stigma? You're going to do some exploration of that when you do your movie project for me this mini-mester. Excuse me. Stigma creates or reinforces interpersonal, financial, employment, and social barriers to accessing care. Stigmatization has led to discrimination and intolerance. Stigmatization has also led to disparity in resource allocation. For instance, psychotropic drugs are covered at lower rates than other meds. There's decreased research dollars available than for other diseases, and so on. And on a personal level, people with mental illness must deal with painful rejection, isolation, and discrimination. Revolving door treatments. The community mental health movement of the 1960s led to a term called deinstitutionalization. What happened here is there was the closure of many state psychiatric hospitals and other facilities who traditionally cared for some of these people. They discharged these folks with mental illness without a safety net, so to speak. Another factor that entered in here was the development of more effective psych drugs. Managed care has led to decreased hospitalizations and decreased length of stay. Insurers favor short-term, time-limited, and cognitive behavioral therapies even when the client's needs are for more intensive therapy of a longer duration. The revolving door treatments have to do with the plight of those folks who enter and leave psych hospitals repeatedly because they can't effectively manage their care independently or within the community. Psychotropic drugs without other therapies are often not enough to produce positive outcomes. Clients must be reintegrated into their communities and social groups and continue to be treated in their communities. Coordination and collaboration among agencies providing mental health services is very much needed. Another issue is called the lack of parity. The lack of parity has to do with an inequality between insurance coverage for mental illness and other diseases that exists yet today. Often, there is a gap between effective treatment and what the insurer will pay. So there was a couple of laws that came out in 2008. I really can't read. The Paul Wellstone and Pete, I think his name is Dementia, Mental Health Parity and Addiction Equity Act of 2008 is a federal law that generally prevents group health plans and health insurance issuers that provide mental health or substance use disorder benefits from imposing less favorable benefit limitations on those benefits than on medical surgical benefits. But the problem with this law is it does not apply directly to small group health plans. Although its requirements are applied indirectly in connection with the Affordable Care Act's essential health benefit requirements are not sometimes the same. So we're going to see a lot of disparity as we look at care for people with mental illness. The last thing is a limited access to services. So if you heard that confusion just a minute ago, I'm sitting here in my office. It's 7:26. I'm trying to get this podcast up and ready for you guys so you have it. And the light went off because when you're sitting still in your office after so many minutes, the light automatically goes out. So I stood up, but the light didn't seem to recognize me, so I had to walk around a minute to get it to come back on. But anyway, back to our slide. Limited access to services. A fragmented mental health care system results in inadequate, inappropriate, or no care. It is difficult for clients and families to determine what services are needed and where to find them. The other issue here is that practice lags research regarding the effectiveness of various treatments. So if you're getting the impression that there's a lot of problems inherent in our care of people with mental illness, there is. And we'll talk about that when we have some of our simulations and when we do clinical together. So more about this later. Here's a little YouTube video, and it's called A Mental Health Perspective. And the woman's name is Ruby Wax, and she's a comedian. But she has a mental illness, and she does a good job about talking about her experience and the stigmatization that she has suffered. But she does it in a pretty funny way. So if you're so inclined, you can watch this little video clip, not very long. So I have a question for you. Which of the following refers to the inequality between coverage for mental illnesses and other diseases? So I'll give you a minute to think. If you chose C, which is the lack of parity, you chose wisely. This refers to the inequality between insurance coverage for mental illness and other diseases. You might want to look at your own policies. See if you have insurance, see what your insurance policy says about covering mental illness, substance abuse, and that. You may find that for some of these, it's covered at 50%, whereas if you go out and break your leg, it's covered at 80%. So you're going to see some differences. They're trying to legislate some changes in that, but we're not seeing those huge changes yet. What are some aspects of psychiatric care then affected by culture? Well, here's our list. And culture, what I want you to keep in mind is that culture can influence perceptions of health and illness, as well as how, when, and why people seek treatment for health problems. This is especially true for mental health. Many aspects of psychiatric care involve, and you can see on the slide, self-perception, roles and relationships, family dynamics and interactions, attitudes toward medications, values, community supports. Before mental health care providers can administer appropriate and effective therapies or treatment, they must understand a client's cultural context and how it may influence his or her attitude toward the particular health concern, its causes, and its treatment. So we get into a problem when healthcare providers exhibit ethnocentric attitudes. Ethnocentric is, involved in these 4 points on the slide. First one being prejudice. And prejudice, as you well know from previous study, is preconceived opinions about other people or groups based on hearsay, perceptions, or emotions. Stereotyping is believing that one member of a cultural group will display certain behaviors or hold certain attitudes, usually negative, simply because he or she is a member of that cultural group. Discrimination is where we see differential treatment based on race, class, sex, or other variables, rather than on individual merit. Stigmatization is the attribution of negative characteristics or identity to one person or group, causing feelings of rejection, alienation, and ostracization from society. So, what are some of the reasons then that minority groups in particular do not seek mental health services? First reason is stress. Stress oftentimes is experienced perhaps from forced migration, dislocation, or immigration. The second point, they might have an inability to speak or comprehend the dominant language. You can cross out the 3 there. I don't know where that came from when I was typing, but it showed up. Differences in religious beliefs and practices, environmental stress, which has to do with poverty or lack of equal access to education, employment, housing, or medical care. Culture-specific beliefs about seeking help, the use of traditional healers and alternative medicines, differing values and attitudes, and misinterpretation of behaviors. So, what are some disparities in mental health that affect treatment? We have variability and vulnerability. The variability in incidence of mental illness among different cultural groups may be due to differences in genetic vulnerability. Biologic variations may be directly related to race, including body structure, skin color, genetic code variations, susceptibility to disease, nutritional preferences and deficiencies, and psychological characteristics. Also, many people of color face issues related to poverty, thus increasing rates of illness, homicide, alcohol abuse, and infant mortality. The second point is ethnopharmacology. These are where you see racial and ethnic differences which reflect both genetics and environmental influences in response to meds. Metabolic differences influence drugs' safety and effectiveness, maybe leading to more toxicity. Different generic substitutions for brand name drugs may lead to problems with effectiveness and toxicity, especially those patients with a slow metabolism, or what we call slow metabolizers with drugs. Monitoring drug levels is important. Some people may even be non-responders with a genetic basis for the lack of response. Nurses must be aware that people from all parts of the world use traditional, complementary, or alternative medical practices and meds. 158 million U.S. adults and more than 50% of the industrial world have used alternative modalities at least once. It is important for healthcare providers to document these practices. For instance, there was a herbal that became highly popular several years ago. I'd say at least 15 years ago. And if you've ever heard of St. John's wort, people were using it for depression, for instance. And you can buy it at Walmart. If you've never heard of it, next time you're in Walmart, go look at the herbals and you'll find it. St. John's wort. Accessibility. Typically, mainstream mental health services have failed to adequately meet the needs of persons of color. Furthermore, many people of color underuse health services. Failure to use health services like preventive services may be related to cost, language, cultural barriers, fear, or apprehension. Racial bias. Clients from non-white populations are institutionalized far more frequently than whites. Racial bias affects such factors as definition of dangerousness, severity of diagnoses, labels, and choices of treatment. Your book talked about the case of Junius Wilson, and I want to share that with you so you're aware that, we have quite a history here. In 1925, Junius Wilson, a 17-year-old black man, was charged with attempted rape in the New Hanover community of Castlehane, North Carolina. In court, he was found incompetent to stand trial. The charges were dropped after he arrived at Cherry State Hospital, a state mental institution. Junius was castrated and remained in a locked mental ward for 69 years. In the 1920s, castration was standard procedure for black men accused of rape. John Badgett, Deputy Director of the State Division of Mental Health, states that Wilson has been the victim of social politics that we look back on now and are deeply troubled by. In 1992, after a review of Wilson's medical records, a social worker discovered that Wilson was deaf, not mentally ill. This discovery, with legal assistance, led to the release of Mr. Wilson and compensation by the state for the abuse and years of treatment. Now you figure he was institutionalized from 1925 to 1992. So how do you compensate a person for being locked up, being castrated all those years? I mean, how does that happen? So that's just one case. The last point, religion or spiritual influences. Many clients from minority populations interpret signs and symptoms of mental illness as spiritual. Therefore, they may choose to seek help from trusted spiritual leaders, thus delaying treatment. Nurses must understand that in many cases, spiritual beliefs provide the structure by which some ethnic groups explain disease. Western medicine is technologically focused, and sometimes its providers consider a client difficult, abnormal, or both. So in your book, there's a story of Leah. And if you haven't had an opportunity to read this book, it's called The Spirit Catches You and You Fall Down, A Hmong Child, Her American Doctors, and the Collision of Two Cultures. Leah had a seizure disorder. Providers asked what caused it, and Leah's family indicated soul loss, S-O-U-L, loss, which began when an older sister slammed the door and scared the soul from the child's body. However, when providers attempted to administer traditional healing methods, the family expressed reluctance, saying, "You should give Leah medicine to take for a week, but no longer. After she is well, she should stop taking the medicine. You should not treat her by taking her blood or the fluid from her backbone. Leah should also be treated at home with our Hmong medicines and by sacrificing pigs and chickens. We hope Leah will be healthy, but we are not sure we want her to stop shaking forever because it makes her noble in our culture, and when she grows up she might become a shaman." In this circumstance, everyone involved was concerned for Leah's health care, yet no one explored the family's perception of the illness. For example, shaking was a blessing with Leah's potential to become a shaman. This exploration of the cultural misunderstanding between the medical community and the Laotian refugee family underscores how well-meaning families and well-meaning healthcare providers can fail to understand each other. Although everyone had good intentions, the inability of the medical community to understand or to communicate with Leah's family, and their inability to understand and to communicate with her physicians resulted in tragic consequences. Under-medication and sporadic treatment resulted in Leah suffering from status epilepticus and subsequently sustaining severe brain damage. Leah is still alive and still lovingly cared for by her mother and siblings. Her medical condition has not changed. Many times cultural challenges are perceived as culture clashes, making it difficult to understand behavior different from the established culture. What are some cultural variables or barriers, if you will, to treatment? Cultural insensitivity, difficulty understanding appointment procedures, lack of public transportation, signs written in a language not understood by the client, and formidable-looking buildings. In addition, many services are inaccessible because of location, hours of service, etc. These institutional structures combine to preclude a culturally inviting environment. So I must ask you, what do you think about this statement? Is the following statement true or false? open-ended questions that allow clients to tell nurses about how they view relationships, the meaning of their illness, or what kinds of coping have helped them in the past can yield information about spiritual concerns and practices that nurses might include in plans of care. If you said this was true, you are correct. And what we have to keep in mind when we're working with patients, either cultural context or whatever, that spirituality is an important part of care as well, and it is encompassed in our holistic view. Are there situations, though, particularly when working with clients with mental illness, in which spiritual interventions are contraindicated? When clients are psychotic or delusional, when clients have made it clear that they do not want to participate in these interventions, with minors whose parents are unaware that their children are participating in an activity contrary to their denomination and faith, this can actually result in unwanted legal repercussions. And I'm going to stop this podcast here so it doesn't get so long. I will do part 2 right after this, and I'll get them both posted for you.